Thank you very much for your invitation. So we'll go straight in because we are a little bit late. So bicuspid aortic valve is the most common congenital heart defect in about 1 to 2% of population with a 3-to-1 male preponderance. 10 to 20% of patients have familial inheritance, which is autosomal dominant with incomplete penetrance. And bicuspid aortic valve also coexists with other congenital cardiovascular defects. Especially coarctation of the aorta, arch hypoplasia, in fact 50% of cases, and also aortopathies. There are some syndromes as well, congenital syndrome, that are associated with bicuspid aortic valve. Our practice at present is guided by a series of recommendations, guidelines on the management of valve disease, also the ACHD recommendation, and we have the management of aortic disease as well. A recent study just published at the end of last year by the team from Vienna, from Austria, has looked at the national history of a large cohort of consecutive patients, 581 patients, that were followed up in a dedicated valve clinic. And they demonstrated actually that the state-of-the-art care results in very good survival, 94.5% at 10 years, with low rates of effective endocarditis, aortic dissection, and sudden death. What is actually important to stress from this study is if you look at the bottom left slide diagram, you see that patients with severe, as well as patients with moderate aortic stenosis in bicuspid valve, have quite reduced survival and high risk of negative outcomes. Also, the outcomes are worse in patients with severe aortic regurgitation and patients that have some degree of dilatation of the aorta from the time they are detected. It's important when you look at the population group, actually they've had in Vienna, it's the predominance in their group was the aortic regurgitation, with aortic stenosis actually increasing progressively with age. So in our presentation, I'm going to touch a little bit on aortic valve stenosis, aortic regurgitation, and the aortopathy. I'm not going to talk about infective endocarditis, which can be present actually in 10 to 30% of these patients. And the rate of aortic dissection is relatively low, estimated at 0.6%. So let's have first look at isolated aortic valve stenosis in patients with bicuspid aortic valve. So aortic stenosis is reported as being the most common complication of bicuspid aortic valve. In large series of excited stenotic valves, 59% of patients under the age of 70 had bicuspid aortic valve, and 41% of patients older than 70. Also, progression of the stenosis depends on valve morphology. And we know, for example, that the patients that have fusion of 2 of the commissures, of the 3 commissures, have much higher incidence of surgery at a young age, usually around the age of 34, 35. And also patients with type 1 bicuspid valves have a higher incidence of surgery than the one with type 2. Initial severity of the valve, the degree of calcification, and also association with other risks like atherosclerosis risk factors and age over 60 are also contribute towards faster progression of the disease. We know that prognosis is good and sudden death is rare in patients that are asymptomatic as long as they have good exercise tolerance, even if the stenosis is severe. However, as soon as the symptoms develop, the prognosis deteriorates quite quickly, so we cannot keep these patients on the waiting list for long. A recent study published in the States has shown that the most frequent cause of cardiovascular death in these patients with bicuspid aortic valve is the symptomatic severe aortic stenosis. And we see that in their population group, in their cohort, around 43% of patients, symptomatic severe aortic stenosis did not have any form of procedure. And we can see their mortality being much worse. Well, we thought that maybe in UK we are better off, but unfortunately not. So looking at a study that was published in 2020, it actually includes a statistic analysis from 2019, which shows that the burden on patients with severe aortic stenosis in UK is extremely high. So if seeing here an estimation of patients with severe aortic stenosis reaching almost 300,000 patients, of nearly 200,000 have severe symptomatic aortic stenosis. And if we look on the right at the capacity in the NHS in the same year, 2018 to 2019, actually the total number of procedures, including TAVI and surgical AVR, plus and minus bypass, were around 13,000. And it is believed that around 10,000 of this would have been for severe aortic stenosis. And this represents about 50% of the total projected to be developing symptoms of severe AS every year. So we have a very high demand for treatment of patients with symptomatic aortic stenosis that we are not meeting at present in UK. So with regards to predictors of outcomes, so in patients that are asymptomatic for severe aortic stenosis, you already have in the guidelines a reference on the fact that there is a need for early intervention. So a recent publication of a meta-analysis of 2 randomized trials, AVATAR and Recovery, have shown that early intervention resulted in 55% reduction in all-case mortality and 79% reduction in risk of hospitalization of heart failure. We also had a meta-analysis of 8 other observational studies that showed improved mortality in patients treated with early intervention. So, in accordance to our guidelines, indications for surgery in aortic stenosis include definitely patients with severe symptomatic aortic stenosis, but there is also a note that patients with asymptomatic severe aortic stenosis should be considered for intervention if one or more predictors of symptoms of adverse outcome are present if the risk for procedure is low. So what are predictors of adverse outcome in asymptomatic severe aortic stenosis? And you actually see this includes not only clinical characteristics like age over 60 and atherosclerotic risk, but we have lots of echocardiographic parameters that have been shown to predict adverse outcome. And we see here severely calcified valves, especially that's confirmed, or CT calcium score, peak aortic velocity over 5 meters per second, a deterioration, progression, decrease in left ventricular ejection fraction, also the rate of hemodynamic progression of the disease, excessive left ventricular hypertrophy, especially in patients with low stroke volume index, pulmonary hypertension if it's confirmed by invasive measurements, and more recent studies as well the value of GLS and cutoff points for GLS to predict adverse outcomes. In patients with aortic stenosis, the exercise stress testing is extremely important. Any form of stress. Bike exercise would be ideal, but not all patients are able to exercise, especially if they are elderly. So any form, even if you look at treadmill or 6 minutes walk or low dose dobutamine, are very useful and bring in prognostic information for these patients. Biomarkers, at present we just have one biomarker. We should really look for more biomarkers because just one single doesn't have very high sensitivity. So looking at very high raised levels of the NT-proBNP, but you need to exclude other explanations for that. And the recent studies on CMR has also shown that mid-wall late gadolinium enhancement accumulates rapidly as the process of aortic stenosis progresses. And actually, not only that it's irreversible, but it also continues to progress after the valve has been replaced. So now, when shall we intervene in patients with moderate aortic stenosis? Or do we have evidence we should intervene in these patients? This is not covered at all by the current guidelines. There is growing evidence of the harmful clinical impact of moderate aortic stenosis, and we know that about 1/3 of these patients with moderate AS progress to severe AS in about 2 years. A heart valve clinical international database actually showed a 78% mortality in moderate AS patients over an 8 years period of follow-up. And actually, intervention in patients with moderate aortic stenosis and heart failure symptoms is considered as being clinically reasonable. And that's as well because patients with asymptomatic moderate aortic stenosis can have early damage of their myocardium, as really shown by some of the CMR studies. Let's look at the aortic regurgitation impact in these patients with bicuspid aortic valve. So our recommendation tells us that aortic valve surgery is clearly indicating severe symptomatic aortic regurgitation patients. But then they also mention that if the patients are asymptomatic, we should first then look at the size of the aorta, because maybe the aorta will fit the criteria needed for surgery in these patients, even if they are not symptomatic. I have highlighted that little number is that because we don't often index, and some of the indexes we do during our current practice are divided, some based on different recommendations on the height, some based on body surface area. So it's important to go back to recommendations specific to the patients that are outside some of the standard height and weight. I will show you a very quick case after. They also stipulate that the aortic valve repair may be considered in selected patients at experience center when durable results are expected. So they don't say you can't operate on these patients. What do we know about intervention in asymptomatic patients with aortic regurgitation? So we first know that the post-operative survival is much worse if we actually keep these patients on the waiting list and we operate once they acutely develop symptoms, NYHA class 3-4 symptoms. So if they are entirely asymptomatic and then develop symptoms and then we decide to bring them up on the intervention list, they do much worse, much worse actually. And we also know that in another center where they actually do a high volume intervention, in asymptomatic or minimal asymptomatic patients with aortic regurgitation with good ejection fraction, they show a significant improved long-term survival. So if you look at the red line, much better than the one that sat on the waiting list, although they had asymptomatic aortic regurgitation. What prognostic adverse outcomes do we have for patients with aortic regurgitation that we can use to build up a case to present it in an MDT? So primarily a decline in left ventricle ejection fraction, and these are really included in the recommendation if the risk for surgery is low. So if you have progressive decrease in left ventricle ejection fraction or a progressive increase in left ventricle and diastolic diameters. Also published studies with cutoff for GLS for these patients, that's a hyperdynamic ventricle when they are volume overloaded, have also shown that, for example, GLS under 19.5 has a higher mortality rate. Exercise testing is very useful in these patients as well to unmask symptoms and also assess the functional reserve. But in patients with aortic regurgitation, asymptomatic patients with aortic regurgitation, the CMR has very significant value. In many of these patients, especially the one with very eccentric aortic regurgitation, we tend to underestimate the severity of AR on echocardiography. So having another method to estimate regurgitant fraction and confirm the volumes of the ventricles and function, as well as to visualize the whole ascending aorta, not only portion as we do on transthoracic echo, is very useful. Biomarkers have been proven as well to have incrementing predictive value, especially if we have a baseline and then serial values of BNP, not the same type of values 3 times higher like in aortic stenosis. Aortic dilatation in bicuspid aortic valve. So we know that ascending aortic dilatation is quite common in patients with bicuspid valve, even in the absence of valve pathology. And the main causes that have been described, you see a diagram in here with loads of factors, but the main one are the mechanical and hemodynamic factors, which are secondary to the valve disease, but also genetic factors with multiple genes that have been described, have been associated with this aortopathy. The risk of the dissection, though, in these patients is lower and definitely lower than Marfan. So you'll see there's a more conservative management of aortopathy in these patients. So very quickly, I'll show you a clinical case, a 20 years old gentleman who presented with persistent hypertension, The GP referred him for a transthoracic echo that showed the bicuspid aortic valve with, you see, type 0 with AP position, with normally functioning valve, no stenosis, no regurgitation, but a significantly dilated aortic root and ascending aorta. The arch on transthoracic echo was not well seen, but the Doppler velocities did not really raise any suspicion of coarctation. However, patient was referred for CMR, this demonstrated bicuspid aortic valve with a transverse aortic arch and critical coarctation. You can see that in this image on the right-hand side in here. It was, the coarctation was around 2 centimeters below the left subclavian. It was a very short segment of coarctation. And the maximum aneurysm of the aorta was measured somewhere between 58 and 63 and confirmed by CT. So patient was referred for surgery. You see the very quick referral from 18 July. Patient already had surgery. And he had a coarctation repair with the excision of that short segment of stenosis and end-to-end anastomosis. And actually, to try to protect the aorta and the support and reduce the size of the aorta, he had an external Pierce procedure. So that's very important to actually, depending on the expertise of the surgeons within the center you work at, it is actually important to look at the best option. It's not only to decide this patient needs surgery, what will be the best surgery for this patient to improve their long-term outcome. And you see here the aorta during the surgery, the aneurysm. So bicuspid aortopathy, what do we know about that? We know that dilatation in these patients is progressive. And much faster than in patients with tricuspid aortic valve. We also know that the risk of aneurysm formation is 80 times higher than in patients with tricuspid aortic valve. And I've marked in red patients with isolated root dilatation. We need to pay special attention to this group because they are usually male, younger, have genetic associated factors, and have a much more malignant progression of the disease. So our current guidelines tell us to actually have a more conservative management for these patients with ascending aorta disease. And you see the recommendations. So I highlighted again some of the factors that we usually don't measure routinely in our practice, especially for small body patients. Also, it's important that even patients like the case we had with aortic coarctation, even if he had surgery, that still has to be taken into account because they still have a high risk of dissection. And the alerts about isolated root dilatation, especially asymmetrical dilatation of the root with aortic regurgitation. And if the aortic bicuspid valve is present in the context of other genetic syndromes, like Lloyd-Dietz and Marfan, which you have different criteria for intervention in these patients. So you need to make sure that if you have a bicuspid valve, you also exclude other syndromes. What do we know about moderate mixed aortic valve disease? Again, there's nothing in the recommendation, very little publication and nothing specific on bicuspid aortic valve that I could find. But actually, we have this recent publication from the end of last year from the Bard Center in London that actually shows that patients with truly moderate mixed aortic valve disease have a very high incidence of death and heart failure. So 43% at 3.5 years. And they also identify a high-risk group within this category, patients that have disproportionately low velocity across the valve with impaired left ventricles and remodeling of the left ventricle. And of course, association with other comorbidities. Okay. Yes, very quick. Just a very quick clinical case. So this is a 40-year-old lady who's been under follow-up for moderate mixed bicuspid aortic valve disease for about 5 years in the valve clinic. She had a very strange accident as a teenager when she was karting. She had a road traffic accident, and she had nephrostomy following that, and then a nephropathy, ended up in end-stage renal failure, on dialysis, and had a kidney transplant in 2018. She is hypertensive on treatment by well-controlled hypertension on medication, and she also developed type 2 diabetes post-transplant. She had a transthoracic echo earlier this year that show bicuspid aortic valve. All parameters were in the moderate range for aortic stenosis and moderate aortic regurgitation. The aorta was reported as mildly dilated. There was not index for either height or body surface area. The left ventricle was reported as normal because the volumes were normal within the population group. Even the index volume was normal. However, the end systolic diameter was increased. What was specific about this patient is that she also had some degree of breathlessness for about 3 years. In the last 6 months, that became much worse. She was referred for an exercise stress echo. She was able to exercise only 3 minutes at the lowest level of exercise of the bike. She was only 40 years old. And actually, when we indexed and tried to find other predictors of adverse outcome, we found quite a few. The GLS reduced, the aortic ascending index was in the moderate risk range. She was symptomatic, and systolic diameters actually was already in the recommendation for intervention for surgery. She was referred to MDT, discussed, and now is being referred for surgical review, and she's awaiting a CMR at the end of this month and has a surgical appointment next month. So early intervention in asymptomatic patients with both severe and moderate bicuspid aortic valve, it is possible, but it is complex, has to be individualized, and has to take into account the benefits and risks, and in young patients, the experience of the surgeons within the center. Because you need to consider, are you going to repair that valve? Can you do a balloon? Is a Ross or Pearce procedure that can be done in this patient? Is there expertise within the center to do that? And also pregnancy planning and management of this patient, because many of them are very young. So in conclusion, aortic valve surgery is indicated in symptomatic severe aortic valve disease, and we must address the unmet, very high demand for treatment at present in UK. There is strong evidence that intervention could be considered in asymptomatic severe aortic valve stenosis with predictors of adverse outcome. There is growing evidence that intervention in patients with moderate aortic stenosis and heart failure symptoms is clinically reasonable. Also, it's been demonstrated that patients with moderate mixed aortic valve disease have a high incidence of death and heart failure hospitalization. With regards to the bicuspid aortopathy, the recommendation actually suggests a more conservative management because the risk of dissection is lower, around 0.6% in this population group. But we do need prospective studies to assess the predictive value of more biomarkers rather than just NT-proBNP, and also to look at potential intervention to slow down the progression of the valve disease and aortopathy and guide the best timing of intervention in patients with bicuspid aortic valve. Thank you.